So Mohamed had asked me to cover amenorrhea, which can be a broad subject, but I'm going to try and focus on the most practical and cost-effective approaches that I've come up with over the past 30 years in practice. And so hopefully I'll share some wisdom with you all in such a way that it's useful and that you'll be able to really understand and begin to think about how to approach this patient as you are seeing the patient, rather than relying on perhaps just laboratory testing. And so we'll go back to the time-honored tradition of the using our clinical expertise. Now, one of the things that I want to emphasize is this presentation will be interactive. I know it's different from the other speakers, perhaps. I want to engage your thought process and practice in active learning. So as part of it, I'm going to ask for responses from the audience. You can either put it on chat, or if you can unmute your microphone, if you're able, you can respond to some of the queries that I'm going to give you as we go through aspects of evaluation of a patient with amenorrhea. Overall, the learning objectives is to use the clinical history, your own powers of observation, which may be underutilized, I think, in clinical medicine, and the physical examination in the assessment of amenorrhea. After you have gone over the history, observed the patient during the history and physical exam, then select the most appropriate and cost-effective approaches for the evaluation and come to a diagnosis. I would say that 90% of the time after I'm done interviewing the patient, examining the patient, I have the diagnosis, and Dr. Bedaiwy can attest to that fact as he was seeing patients with me during his fellowship. And lastly, you'll be able to define physiologic dysfunction and what is the cause of the amenorrhea so that you can go on to treatment in a very, very short time. So in this approach, I'm going to assume that all of you have done a pregnancy test in a patient with reproductive potential and she is not pregnant. Okay, so this is the basis for our discussion. I'll assume that all of you have some baseline knowledge of the control of puberty and the neuroendocrine regulation of the hypothalamic pituitary ovarian axis. I'm going to try and emphasize that as we teach fellows and residents, we tend to use a lot of panels for lab testing, and we perhaps overuse it. And certainly in certain countries, this may not be available, or in certain rural areas, it's not available. And I'm going to emphasize going back to the old time practice of clinical observation with the understanding that the patient is a target tissue and a bioassay for hormones that are circulating in her system. And this affects your overall diagnosis of the underlying cause of amenorrhea. And I'm going to emphasize the value of the history and physical exam. So let's look at some familiar definitions. Primary amenorrhea can be defined as in most textbooks, an individual female who is at 15, but no secondary sex characteristics. And so estrogen exposure is not evident in your assessment. Also, individuals who fail to develop breast structures by the age of 13. In contrast, the vast majority of patients we deal with, probably 95 to almost 99%, have secondary amenorrhea, and we arbitrarily define this as no menses for 3 months. And obviously, in the absence of pregnancy, lactation, or menopause, this amenorrhea incidence isn't very high. It's under 5% for most populations. And the usual causes are polycystic ovarian syndrome, hypothalamic amenorrhea, which we'll talk about a little bit, the high prolactin individuals, and individuals with occult or induced primary ovarian insufficiency that you may come across. So what are some other factoids that we deal with? Because this is an international audience, there is a WHO grouping, group 1 being no endogenous estrogen production. These are individuals that, when you do the assessment of FSH, have either normal or low FSH. So the FSH is usually below 15 IUs per ml. The prolactin levels are in the normal range or low. That is under 20 nanograms per DL in the US. I don't recall the units in the international units. And if there's any imaging done, normal Celeturcica on imaging, either with CT or MRI with contrast. The second group, WHO group 2, are individuals with amenorrhea that have evidence of estrogen production with FSH in the normal range and normal prolactin, and that's probably the most common group. And the third group are individuals with primary ovarian insufficiency with elevated FSH due to the hypothalamic drive and the lack of estrogen production from gonadal tissue. So let's first start, as most clinicians, with a clinical scenario. This is not atypical for patients that might present to your office or clinic. A patient with no menses for the past 6 months. So she fits the definition of secondary amenorrhea. And there is a broad range of differential diagnoses. Does she have a problem with her thyroid axis? Does she have high prolactin? Or is the ovary not being driven in a normal fashion, or there's something intrinsically wrong with gonadal function? Perhaps she has a shutdown in her GnRH axis, such that there is reduced hypothalamic drive, or she may have, commonly in the US, as most women are getting obese, some variant of polycystic ovarian syndrome. So by history, we focus on adrenarche age, menarche age, and previous history of regular or irregular cycles. These are important milestones that you may want to explore, although in most women that have regular cycles, it probably isn't as important. If they've had any pregnancies and what kind of contraception they may be using. An example would be the use of Depo-Provera, which is quite common in our clinic population, which may induce a prolonged shutdown of the hypothalamic pituitary ovarian axis well beyond the time that the progesterone drug is off of their system, even though it's in the depot form. And so amenorrhea can last up to 1 year following Depo-Provera use. You need to begin probing for hormonal disturbances. So you're beginning to think about what are some of the causes, both deductively and inductively. So I want to kind of force you to think about the patient as you're interviewing the patients through the history. I also begin to look at patients, either nowadays we have telemedicine, so we're looking at them on Zoom or in person. And I would look at for acne, any kind of midline facial hair as we're interviewing the patient. An important component that we tend to ignore as clinicians and physicians are sleep patterns. So the lack of sleep pattern can upset the diurnal variation, the cortisol variation, and introduce a variety of changes to the hypothalamic pituitary unit, perhaps not a direct impact, but an indirect impact. Is the patient on any kind of significant diet, vegetarian only, skipping meals, and or protein only diet, things of that nature. The exercise pattern is very important. We have individuals who are athletes or want to be athletes or in training, and individuals from our baseline studies of women with hypothalamic pituitary dysfunction, i.e. hypothalamic amenorrhea. Generally, when you run beyond 15 miles per week in training, become either irregular or amenorrheic. We also see this in ballerinas that maintain a low body weight and obviously are very, very physically active, so that the energy outflow is really not concordant with the energy intake. Weight changes are a major issue. I always obtain a BMI, and I am concerned when the BMI is less than 20 or greater than 40. There is an ethnic component to this, as we see women of different races. Obviously, BMIs of less than 20 in an Asian may be normal, but in a Caucasian may not be. And BMIs greater than 40, we sometimes will see women with no disturbances in their menstrual cycles, especially the African Americans in the United States. And then lastly, one thing that people don't ask about is if they're in school, how they're doing, what are their grades? Are they having stresses at work if they're working? And if there are any relationship issues. These are more subtle psychological stress events that can perturb the hypothalamic pituitary axis and therefore lead to a disordered secretion of GnRH and LH and FSH downstream. In terms of vital signs, they're somewhat less important, but obviously in someone who's obese and hypertensive, you have to think about glucocorticoid excess. In individuals with bradycardia, that is heart rate less than 60 at rest, or tachycardia, you have to think about some disturbance in the thyroid hormone axis, which affects basal metabolic rate. Oftentimes in women that you're worried about gonadal dysgenesis, where you have coarctation in the aorta as a possibility, there may be a delay in a transmission from the radial pulse to the lower extremity femoral pulse. So this may be an early sign without a lot of imaging studies to show that. The height, weight, and BMI are important, as I alluded to, as we see that in individuals with eating disorders such as anorexia or bulimia or growth hormone disorders. So one of the things that I try and do is the unconscious observation, and that is to look at the habitus. On the left is a individual, we assume that her habitus is female, but it could be male, except that it shows her lower genitalia. Both boys and girls will have the same prepubertal habitus. Note that the waist, hip, and chest are all in line, or almost linear. There is equal proportions of growth in the long bones and extremities, and except for the longer hair, this could be a boy, and if you didn't see the genitalia, this could be a boy. We all have, I think, unconscious bias when we look at individuals in a crowd, especially a very good-looking man for the female physicians and providers, or a very attractive woman. And what do we notice about those features? The audience participation. What are the features in the that you would notice in a female. Let's go with this first. Everyone is silent. There's 51 people. No takers. Okay. The
waist
is usually smaller than the
waist of the patient.
The hip. The buttocks are usually more prominent compared to the male, which is flat. The shoulders are rounded rather than more linear. And the neck muscles are less prominent. The so-called very, very slender neck. And this is a bioassay for estrogen driving the adipose tissue fat distribution. Obviously, we turn her around, you can then see breast development as well, but looking from the rear, which sometimes in a crowd, that's all you have, you can tell whether it's not just by the dress, but a male or female because of those features, because lots of females now wear slacks or blue jeans and shirts, and so you can still tell whether they're male or female by the habitus. So these are important observations. The other thing that we need to pay attention to is the not only the habitus, but the fat distribution. So these are things that perhaps you've heard about. So depending on the deposition, so these are women in this group, and we've sort of, shall we say, distorted the image a little bit. This is an individual with an apple distribution. So large amount of abdominal fat distribution, whereas this individual is more of a pear and has a more prominent waist compared to the, hips compared to the waist. And so this distribution may represent an increase in androgen effect, sort of the beer belly that we see in men, but you can also see with androgen effects in women. So this is an androgen-driven effect in females. And although I don't think this is a terrific example, this is an individual sort of with a little bit of an apple appearance, and this is one that's more pear-shaped. So I think these are examples of where you pay attention to this and begin to think as you're examining the patient, is this woman showing some androgen or more predominantly estrogen? So this reflects the estrogen to androgen ratio on the habitus. So the types of habitus, then we talked a little bit about the female, the male, and the neutral, where there has been no exposure to sex steroids. There may be differences in individuals with growth hormone because you get an exaggeration of certain bony features that have closed, and the growth hormone causes additional growth, not at the end plates, but overall. And so you get this frontal bossing and digital changes. And so these may be very subtle at the beginning and much more prominent at the end. We talked about the fat distribution, reflecting the androgen-estrogen balance, and the waist to hip ratio, which also represents the androgen-estrogen balance, and the predisposition, especially if the androgen predominance is there, for insulin resistance and eventual development of a condition we are all seeing more of in our developing world as well, metabolic syndrome, where there is an excess amount of insulin resistant tissue, and high insulin levels are required to drive the glucose and fatty acids metabolism. And obviously the classic centripetal fat distribution, which is a representation of glucocorticoid excess. So can in this picture, can any of you identify the mother, the daughter, and which is the older daughter? This is the mother is pretty easy. It's this person, but which one is the older daughter? And how would you query that?
Maybe the one to the left is older.
Aha. Why do you say that?
Because she's having some recession of the head over the head. This is going with the older woman.
Okay. Actually, it's the one on the right, the blonde, that's the older daughter. So I have a problem with this screen. I have this major white thing when I tap the QA. I don't know if, not seen this on a Zoom before. Hang on for a minute.
We can't see your cursor, Dr. Liu.
Okay. I'm just trying to get rid of the chat, and it's in the middle of the screen.
Oh, I see you have you have an Apple, I think.
Yeah. I can't get rid of it. Maybe I can. Let me stop sharing and see if it goes away, and we'll start sharing again. Yep, I got rid of it. All right. So now it's not working. So getting back to the habitus, we talked about the fat distribution, but now we need to pay attention to muscle distribution. And muscle distribution in the female is primarily androgen-driven effects. You begin to see increase in upper shoulder girdle muscles. Many women in their dress will have what we call shoulder pads to make the shoulders a little bit less rounded to look better. Obviously, there is increase in muscle mass, especially if you can see the arms and the biceps, triceps, and obviously in women that are virilized, some increase in the larynx that is visible. The skeletal proportions are important because if you have a delay in the estrogen closing the epiphyses, you begin to see conditions which delay the epithelial fusion. And so when you measure the height, the arm span, and the pubis to floor dimensions, they are not, the arm span to pubis floor dimensions are not 1-to-1 in comparison to the height. And so there is a greater arm span than is typical. And so these individuals have a longer arm span. And you see that in individuals with delayed puberty. So going back to the powers of observation, what are the noted physical features in this individual? And I probably, if I do chat, I don't know if it's going to screw it up, but we'll see. No typing yet. Hopefully this will go away when I hit chat again. It doesn't go away. Well, that's not working. All right, let me go back to share screen again. So this individual is not one of my patients, but I have a patient very similar to this. So she has, number one, notice the prominent veins. Notice a definition in the abs. Notice the little bit of sideburn here. Notice that. I don't know if she shaved or used some sort of depilatory on her face, but I would expect some increase in facial hair. The shoulders are not rounded, they're very, very square. So this individual is using anabolic steroids in addition to weight training. And so this is a bioassay for excess, an extreme example, excess of anabolic steroids. It's not going, okay, we'll go to this. So this is an example of an individual with what syndrome? Are they unmuted? Is that the free fly person that controls that?
Yes,
All the
free
participants
fly
can,
controls this. I think there is a problem on the chat that they are working on right now.
Okay, that's all right. So this is an individual, obviously, with a web neck. We don't have her height because I don't have a scale on here. She is shorter. And if you look at her mouth on the inside, there's a ogival palate, which is this kind of dip in the, and this is gonadal dysgenesis. This individual did not have double eyelashes, but I have seen some with double row on the upper eyelashes. Now this happens in non-gonadal dysgenesis patients as well, but this is a noted feature. And so there are individuals with gonadal dysgenesis that don't have the typical web neck and are not quite as short that you can make these diagnoses based on other physical features. What about this individual? And I oftentimes do observation during the interview. In fact, Dr. Bedaiwy may have remembered a patient that said to me as I was interviewing her with Dr. Bedaiwy, "You're stripping me with your eyes," even though she had all her clothes on. So this individual has an increase in acne. You can see up here in the chin area and the malar area. And this individual has acanthosis nigricans. This is a second individual with that. And this reflects hyperpigmentation in the skin folds. You see it in the neck, you'll see it in the armpit area. If she has a pannus, you'll see it in the fold of the pannus and also on the perineum. These are the typical areas, and they represent an increase in pigmentation due to insulin resistance stimulating the skin and the melanin producing portion. And it's especially notable in the midline because of an increase in the epidermal and hair follicles in the midline for conversion of normal or slightly elevated testosterone levels by the enzyme 5-alpha reductase to dihydrotestosterone. So this is an important feature that you may find in your examination. Other features that you may want to look at is coarseness of the frontal bone and the mandible. A more square mandible in a female might be worrisome. Increase in the bony cartilage and joints, and obviously in gonadal dysgenesis, low set ears or web neck, as we saw in that individual. I oftentimes will ask individuals to kind of tilt their head up when I'm examining them to take a look at the thyroid. So that helps with looking at the thyroid gland as they swallow. We talked about some of these features already in the gonadal dysgenesis, the double eyelashes, and the ogival palate. Fundus you might want to look at, see if they have retinitis pigmentosa, which suggests there's some central mechanism. Although we tend not to do these, confrontational visual fields will pick up sometimes visual field effects suggesting that there is something compressing the optic chiasm from a pituitary or central lesion. In general, they're not very sensitive, and you have to probably use Goldman perimeter visual fields to really see that. And obviously, for individuals with overt clinical hyperthyroidism that might be tachycardic, you might see what I call lid lag. That is, you have the patient follow your finger and ask him to visualize your finger. As you move your finger up and down, you should not see the whites of their top of the eye, because the lid will move with the eye. And if you see the white sclera part of the eye, that would suggest that they have lid lag. So this is an individual with a large thyroid. In fact, one of the newscasters on national TV, someone sent her an email because they noted that she had an unusual protuberance in her neck, and they kind of suggested that she see a physician, and she was found to have hyperthyroidism and an autoimmune thyroiditis component. And obviously, if you look at the suboccipital fat pad, you can see this in glucocorticoid excess, although you can see it in other individuals with obesity, but people that have glucocorticoid excess will also not have regular menstrual cycles and may be amenorrheic, but they're also usually hypertensive as well. So looking at the skin, you can see changes that may suggest hypopituitary, very, very white alabaster skin that's hairless, pale, and very, very smooth. If there's moist skin suggesting fine perspiration, it may suggest hypermetabolic status from thyroid. Obviously, acne, oily skin is a marker for androgen excess, and pigmentation, especially in the folds, would suggest an increase in the alpha MSH or ACTH axis. And we talked a little bit about acanthosis nigricans, which usually is a hallmark of individuals with polycystic ovarian syndrome with insulin resistance. So there are many, many ways to make the diagnosis other than drawing blood samples. Examination of the hair. So there are two kinds of hair in adults. There is the very fine, very villous hair. You tend to see that more in young prepubertal individuals. And then there is terminal hair, which is androgen driven. And obviously there is a strong ethnic genetic component to this. Certain ethnicities have thicker, darker hair, more prominent, and it may be in the family. This is different from a condition called hypertrichosis, which is just generalized increase in body hair, more noted on the extremities rather than in the midline. And I think the key takeaway message from this is that the presence of midline terminal hair, this feature is the most sensitive bioassay for testosterone elevation. And so this is really an amplification of testosterone bioassay as the hair follicles and sweat glands in the midline in both males and females possess 5-alpha reductase enzyme activity. And so this reflects then a sensitive bioassay for a mild testosterone elevation. And you'll see this in individuals that have chronic oligoovulation, where the ovary is being stimulated, but it does not transition into estrogen progesterone production. And so more of the testosterone is not aromatized, and it is in the circulation, and this is an amplification of that elevation. There are other ways to quantitate hair distribution. The the easiest way that I found and the quickest is the method of Barden and Lipsick. They were at the NIH, and they characterized the regions of hair as on the upper lip 1+ if there's hair present there, or on the chin another 1+, and sideburns would be 3+, and 4+ if they have a full beard. The other method, which is a little bit more semi-quantitative, is looking at the entire body, 5 areas, the method of Fairman and Galway. And on this slide, this is an example of that scoring. The first top panel here shows really the Lipsick criteria we talked about for scoring from 1 to 4, full beard being 4. And then the other areas that Fairman and Galway look at are the upper chest and breast area, the midline area in terms of above the pubic triangle, and the pubic area itself with lateralization of that hair to the lateral thighs as well. And then on the back side, if you turn the woman around, in the area of the posterior thigh, and on the back with a special focus on the midline. So this is an example. I have not done Fairman-Galway scoring for long time, and I just use the Lipsick criteria. An example of drawing of a villus versus a terminal hair follicle, and differences in the villus versus the terminal hair. So what is wrong with this individual? This is a bioassay, obviously, for androgen. Anyone want to? This individual has the following features: on the face, upper chest, scalp, pelvic area.
Well, this probably bordering into virilization. It's more than just a
So this
hyperandrogenism.
person is virilized, and at first we thought that she might have a adrenal gland tumor. This one we actually had to measure the testosterone levels to really make a clear diagnosis, but it turned out not to be. It turned out to be bilateral hyperthecosis. But again, very, very interesting. Not this particular patient, but I have recently had an individual who was a minister whose libido was requiring her husband to be intimate with her on a daily basis. And the psychiatrist saw her because she was thinking that there was something wrong with her, and recommended that she see us, and we made the diagnosis of virilization. So going down to the breasts, it's a bioassay for androgens, estrogens, and progestins. Estrogens usually drive the ductal development in the breast, and the progestin drives the axinar or glandular development in breast tissue. So when one is stimulating breast tissue in transgender patients, or taking a Turner's gonadodysgenesis patient through female puberty, one has to not just use estrogens, but also to add some progestin to allow breast development to be normalized, so that the breasts do not have just an excess of ducts without the acinar development. We'll talk a little bit about Tanner staging. One of the things that physicians and providers don't do is to actually compress the breast to look for secretions and look for galactorrhea. This is a bioassay, obviously, for prolactin. Going first to the Tanner staging, breast development. This is an O photograph from the original, I think, Tanner publication. These are from breast 1 to breast 5. So in prepubertal, you just see essentially an areolar, a small areolar nipple, really very little, if any, breast tissue. There is in stage 2 a budding you can see on lateral view with some enlargement of the areolar, and in stage 3 enlargement of the breast further with a single mound. This does not mean that the cup size of the breast is the only feature. Obviously, there are individuals that stay at level 3 with large cup size breasts, and then in 4 you begin to see the areolar come above the mound and papilla changes in the nipple area, and then there's some retraction of the areolar in stage 4. Now, obviously, this individual that they have demonstrated have further enlargement of the breast, but really it's past 3. It's not really the size, but the relationship between the areolar and papillae that really make the staging beyond that. And then I will often, with a chaperone, push on the breast to see if there is any discharge. And you do have to compress the breast tissue, not just pinch the nipple itself. And sometimes it'll be not white or typical of lactation, but it may be clear, it may be green. One of the things you can do is take a wet mount and whatever dye you want to use, look for fat exclusion. This is a fat exclusion showing that these little globules of fat indicate that it's galactorrhea because there are fat globules in breast milk. Now we're down to the pelvic examination, a bioassay for androgens and estrogens is the lower pelvis. Look at clitoral enlargement. The normal size can vary from individual to individual, but if it's bigger than your thumb, then this is definitely a clitoral enlargement. And usually folks have characterized as greater than 1 centimeter in terms of the shaft diameter. There may be Müllerian anomalies that you will notice, i.e. just a blind vaginal pouch, which would explain the amenorrhea. And we're going to look at the characteristics of the vaginal mucosa, the cervical mucus, and obviously you want to look for head and neck zone enlargement. This may not be that evident, obviously, because of the habitus of the patient, so that may limit your ability to really appreciate small and head and neck zone enlargement. Going back to the Tanner staging, you can see that with pubic hair, similar to the breasts, stage 1, there's no pigmented hair. There may be villous hair. And then on the labia majora, you begin to see pigmented hair in stage 2. The hair becomes more pigmented and is spreading to the mones from the labia, so spread to the mones being 1. And then adult type is 4 with a triangular shape. And then lastly, adult distribution to the inner thigh. And in the US at least, many women shave their pubic area, so you'll have to look for the hair follicles themselves. Cervical mucus is something that you can look at in general. If you find cervical mucus dry on a wet mount, you can see it on a slide with a Q-tip. If you see this and you do a progestin challenge, almost always it's positive. So I don't routinely do progestin challenge tests unless they have a issue with instrumentation of the endometrial cavity, such as a DNC, where I'm looking for Asherman syndrome. But if they have a cervix and they have a uterus, this is what I would look for in terms of estrogenized bioassay. And then the speculum exam should show you a well-rugated cervix in in vagina in individuals that are well estrogenized, usually moist, and more ruby red rather than light pink that you see in menopausal women. And this represents on the photomicrograph on the right, thickened epithelium with deep invaginations. In contrast, menopausal atrophic mucosa is on the bottom, showing very, very little papillae, thin epithelial surface, very little in the way of superficial cells in the epithelium, and more basal and intermediate cells. One can also do a pap smear, I guess, to look for the grading, but you're not going to get it back anytime soon, so this doesn't really help you. And then lastly, a lot of people don't do reflexes. You can look at tendon reflexes. The one that sticks in my mind is the Achilles tendon reflex. You have the patient kneel on a chair, and then you tap the Achilles tendon. You're want to look at the relaxation phase. It is delayed, and per the publication, it's a 92% if accurate in the diagnosis of hypothyroidism, believe it or not. There may be peripheral edema from lack of thyroid hormone, but this is usually more evident. And obviously, if patients complain of symptoms of carpal tunnel syndrome, they might be a growth hormone excess due to the ligaments being compressed from the growth of the bony cartilage underneath. So the evaluation then, laboratory-wise, after you've done your history, your physical, and your overall look at the habitus, the hair distribution, the muscle distribution, the skin, breasts, and the internal external genitalia. Most of the time, I would say 90% of the time, I have a pretty good idea what I'm dealing with and have a working diagnosis, and using those approaches. And then finally, if you're still a little bit stumped or you want to confirm your diagnosis, what do you do? And this is stolen from the ASRM Practice Committee. This is available online. Evaluation of women with amenorrhea. This is secondary amenorrhea in the absence of pregnancy. The two key hormones that you should be obtaining is FSH and prolactin. And with just these two alone, you can begin to narrow down the diagnosis if you don't have an idea. So it's either chronic anovulation associated with obesity, or polycystic ovarian syndrome, or functional hypothalamic amenorrhea. And in this case, you would, on history and physical examination, hopefully identify some stressors that contribute to it, whether it's exercise, dietary, or weight loss as one of the causes, or increased environmental stressors. If the prolactin's elevated, then you obviously are thinking about a central lesion. Is it the prolactin-producing tumor of the pituitary, which is the most common, or some other central defect that is preventing the delivery of dopamine to the pituitary gland? So imaging studies then are required for that. If the FSH is increased, and you may find, and one of the things I see more and more of is women exposed to chemotherapy. Due to this component, you're seeing women with decreased ovarian reserve and obviously ovarian insufficiency. You have to think about gonadal dysgenesis as well, because the HP axis functions normally in gonadal dysgenesis, so the FSH is elevated, and you may be able to narrow it down. If the FSH is normal, below 15 and below, and above 2 or 3, you may be dealing with an anatomic defect such as Müllerian dysgenesis. So this is I think a a real simple way to look at these things. In general, the thyroid axis is normal in the vast majority of patients. So let's then go to a final exam, and we're looking at a clinical vignette. Unfortunately, we can't do as much with interaction, but it's a 29-year-old African-American female, gravida 0. Menarche began at age 11. She had increase in body weight from 140 to 260 pounds since high school and community college. When I asked her about her facial hair, she said, I've been shaving once per week for many, many years now. And she gets about 4 cycles a year, none in the past 6 months. Her urine pregnancy test obviously is negative. And she has not used any contraception, has been sexually active with several partners for the past 5 years. So significant, so her family history, mother is also overweight. Mother had gestational diabetes with the last pregnancy. Mother is not in menopause at this point. Maternal grandmother died of a myocardial infarction. Also had a history of adult onset diabetes type 2. Father's history is not known, and she has an older sister who is obese and has irregular, a younger sister who is obese and has irregular menstrual cycles. So looking at her, she really is heavier than she thought she would be. She is 5'6", greater than 300 pounds, so her BMI is over 46. She has increased acne on her face, and what appears to be a vague suggestion of a mustache chin distribution with facial hair. Breast exam and thyroid exam are normal. She has a male type escutcheon. Couldn't feel anything on pelvic exam, and here's an example of her. So she has obviously obesity on top of her other hormonal disturbances. The waist to hip ratio is about 1. She has a pannus, probable anovulation, and based on her face, she has mild increases in androgen level. I don't think she's virilized. So what labs would we order on her? Obviously, urine HCG. Should we be getting androgens? Is she virilized? Probably I would not. In the US, everyone would, but I would not. Certainly, I would evaluate her for cortisol excess because even though she is not hypertensive, I'm concerned that she may be intermittent Cushing's. Certainly, I would get a TSH and prolactin. I probably wouldn't get an LH. I don't think it's as helpful. I'm not looking for an exaggerated ratio of LH to FSH. And certainly I would get an FSH, prolactin, and TSH. That's probably all I would do on her. If I'm going to manage her long-term, however, I need to know more information about her metabolic status. So what's her long-term glucose control? So a hemoglobin A1C would be good. I probably wouldn't do a GTT. I would do an insulin glucose ratio to see how insulin resistant she really is. She's trying to get pregnant. I'm not sure that I would check her male partner yet. I think we're dealing with an oligo-ovulation story, and if we could get her weight down, we could probably induce ovulation and wait to see if she gets pregnant with ovulation. Same with the tubal factor evaluation. The referring physician, however, did all these labs. This is our typical PCOS profile, which you can order on our EMR. I guess you could make the diagnosis without seeing the patient at all if you were to order these tests. However, if you look at the cost of this profile, it exceeds $700 US. I'm sure in Egypt it may be a lot less because you don't charge super extra high rates for assays. Maybe Mohamed will correct me. But she did have some exaggeration in her LH-FSH ratio. Her testosterone by LC mass spec is not that dramatically elevated. It's under 100. Prolactin is normal. TSH is normal. Her adrenal DHEA sulfate measurement is normal. And she does not overproduce 17-hydroxyprogesterone, suggesting no issues with blockade of the cortisol synthesis pathway. So the elevated LH to FSH ratio can occur in 60% of patients. We now rely on, in many cases, especially in OBGYN offices in the US and Europe, ultrasounds, which are readily available. So you're beginning to see these necklace peripheral cysts on the ovary, the necklace pattern. I'm more concerned about her metabolic status, her elevated fasting insulin levels, and obviously long-term, if we're going to manage her, a potential for dyslipidemia with her LDL well above 140. So PCOS features that we see typically in the US, 5 to 10% of reproductive age women. It's probably higher than that. When I made this slide, it's probably closer to 20% in the population that we see from the inner city. Obesity being present in over 60%, some facial hirsutism present in up to 90%, and at least 50% not ovulating at all, and infertility in over half the patients. And so diagnostic criteria, what we find is if we do the assays, high androgen levels, not in the male range, but certainly above premenopausal female range. We, in some cases, will exclude cryptic 21-hydroxylase deficiency rather than congenital adrenal hyperplasia, which is uncommon. I have looked for this a lot, and I've only found maybe 1 or 2 patients, despite having a huge Jewish population in Cleveland. So I'm not sure that this is worthwhile exploring. Obviously, irregular menstrual cycles and clinical evidence of androgen excess, especially in the midline hair structures. And we don't always find polycystic ovaries by ultrasound in this group. So it's not always the case. And you can see PCO appearing ovaries in women with regular menstrual cycles with no evidence for clinical hyperandrogenism. So it can be a misleading if you're just looking at the ultrasound. Just a word about non-classical adrenal hyperplasia or cryptic 21-hydroxylase deficiency. It's much more common in the Eastern European Ashkenazi Jewish population. Maria New was the one that first described this. I don't find that the incidence is 5% at all. I think it's under 1%. It's probably oversubscribed. In my 30 years, I've seen very few. There are different types that she's characterized. So if you want to drill down on this, certainly feel free to look at the Library of Medicine. One thing that we see sometimes is women that are normal weight that have a PCOS diagnosis because of the hirsutism and ovulation, so they have androgen increases, is that there is a increase in visceral fat in these individuals that are associated with insulin resistance. And this is an imaging study showing the increase in visceral fat. Obviously, this is for a research purpose. One would not do that normally in individuals. my predisposition or my working hypothesis of why we see more of the obesity-associated PCOS type patients, which is the majority of the amenorrhea that we see in the office, is that they have a genetic predisposition. This may be an abnormality in the genes that control the glucose metabolic pathway, such as glucose transporters or insulin receptor defects. There is some epidemiologists that feel that there is a evolutionary pressure during early evolution for selecting for thrifty genes. Back in the times when one could not get food on a regular basis, individuals that had thrifty genes that were promoted tended to survive from starvation compared to perhaps individuals that had normal genes. And so this may be a adaptation that has been persisted in our gene pool. And with our acute modernization, we've got cars, bicycles, we don't walk everywhere, so we have decreased physical activity. We have fast foods, which result in increased fat calories, carbohydrate calories. We tend to have more obesity. I'm sure I was in Egypt 3 years ago, and obesity was beginning to be a problem that I noticed just walking around. Insulin resistance that goes along with the increase in adipose tissue, condition that becomes more severe and becomes metabolic syndrome, and type 2 diabetes and other PCO-like syndromes. Some examples of just extreme examples of individuals with hypothalamic amenorrhea due to weight restriction or exercise. In this case, it's weight restriction. That is one of the swimsuit models. And then in this individual with a amenorrhea, normal secondary sex characteristics, 16 years old, coming in with amenorrhea and abdominal pain. Notice the large abdominal bulge. This is an intraoperative picture. And the hymen showing some bulging, normal external genitalia, and then the large amount of hematometria that egressed with the opening of the hymenule. So this is an outflow tract obstruction, easy to diagnose, something you can do in the office. Individual with severe anorexia nervosa being studied at the NIH. And this is a little bit different. This individual has Tanner stage 3 breasts, pubic hair, but is amenorrheic. And similar individual, the pubic hair in these two are a little bit more sparse. Going through our clinical exam, we have a female habitus, normal thyroid exam, breast tissue, no discharge. Tanner, should be Tanner 3, that's my fault. Tanner 3 breasts, sparse pubic hair, Tanner 3, reduced axillary hair, and this individual has a testes with a mild form of androgen receptor defect. So a gonadodysgenesis with androgen defect as well. Very unusual. So I think we'll stop here and move to questions. I apologize, we could not do it interactively. I gave Zoom more credit than it deserved.
Well, thank you, Dr. Liu. That was very practical and informative, and lots of interaction for sure. I think, Professor Mahmoud, you have quite a bit of questions. Do you want to start firing?
All right, so let me go to the top here.
Okay.
Mahmoud,
Yes, sir.
Here you go.
Thank you, Professor Lou, for this very nice presentation. And of course, this is the first time for me to make the use of word bioassay. To make the use of bioassay. This is very nice. Thank you. I have some questions, me and all the audience. Let me address them to you. First, what is the age of 15 years to characterize amenorrhea is universal, or it depends on races or family or something? The age of 15.
So I think that's an arbitrary definition. And it probably is derived from a Caucasian-based database. We know that the menarche occurs earlier and earlier in African Americans. We see that as early as age 8. And so the definition of precocious puberty has been pushed back in the US. And with better nutrition in the Caucasian population, it has been pushed back about 1.5 to 2 years. So 11 is kind of the cutoff that pediatric endocrinologists use for the menarche. So 15 is, I assume that it's some sort of 2 standard deviations from the median or the mean. And so that's an arbitrary cutoff.
Thank you. A question from one of the attendees. How can we manage amenorrhea associated with DMPA or implanon?
Okay, so implanon, when you remove it, doesn't have as great an effect on the HP axis compared to Depo-Provera. We have found Nexplanon and Implanon, which are the 2 progestin-only contraceptives that are very popular. Generally, the Implanon and Nexplanon, we found that they return within about 6 months, usually. With Depo, you can see a prolonged effect for 2 reasons. One is the weight gain with Depo is much more significant. So I think the suppression of the HP axis is not only due to the prolonged Depo effect, which is less predictable from individual to individual, but also due to the weight gain that may occur. And so part of the lack of reactivation of the HP axis is due to the obesity component in part. So the reason for that weight gain is that MPA binds to CBG and has cortisol-like effects. It displaces cortisol from CBG, cortical-binding globulin.
So how can we manage this? How can we reverse the amenorrhea associated with DMPA?
Well, okay.
Just wait or?
Yeah, so with both of them, certainly you can try and lower the estrogen levels by 2 methods. Obviously, Clomid or clomiphene citrate would be one approach. That often works, doesn't always work, but it often works. The second is the use of letrozole, which is used more widely in the United States for PCOS, since the trial that demonstrated it was superior to clomiphene citrate by the NIH reproductive group. So I think both of them can be used. Obviously, you can drive the HP axis with GnRH. I don't know if the GnRH pump is available in Europe. It is in Egypt, but it is available in Europe. It's very expensive. And you can also drive it with gonadotropins. But again, both of them may be more expensive in the sense of for the gonadotropins, you're going to need to monitor more closely. The GnRH, you don't have to monitor very much at all. So you can drive it with both.
Okay.
Would you give a grace period and advise watchful expectancy for some time before trying to induce with Clomid or letrozole?
Would you give what? I
Grace
missed.
period, like watchful expectancy for. You said 6
Yeah, I
months.
mean,
Sometimes
I
they
think
return.
the key, I mean, most people want to get pregnant yesterday when they end up in my office. If they're more than 6 months following depo, usually that's when they get anxious. We can then challenge the HP axis with low estrogen, whether you want to use an anti-estrogen like clomiphene citrate or an aromatase inhibitor like letrozole. But you can certainly drive the HP axis directly or bypass the HP axis with gonadotropins.
If the patient is still using this DMPA or implanon and she wants her menses to come back,
right?
what
So,
can we do?
so once they start cycling, if you stop the clomiphene, they may not restart on their own either. And so the reactivation phenomenon is not as well known because, again, we don't know the exact etiology of why the suppression causes that. I guess the easy answer would be get an FSH. If it's very low, then you know that it's suppressed, and you could probably measure it periodically to say, hey, your ovary's working, it's just you're not driving, your brain's not driving the hypothalamic pituitary axis. So I think that's sort of the easy answer is if your FSH is under 5, you're not going to have a spontaneous cycle. 5 IUs per ml.
Okay. As you know that there is increasing number of teens having PCOS nowadays because of the metabolic syndrome and the bad eating habits and so on. How long can we allow amenorrhea to be? How much for how many cycles to be missed?
Yeah. So what I try and do with those individuals, if they're sexually active and they don't want to get pregnant, you should use a combination oral contraceptive or a progestin IUD or something of that nature. Because if they're having less than a cycle every 4 months, you run the risk of endometrial thickness to the point of hyperplasia. I've seen recently 3 infertility patients with either stage 1 endometrial cancer or atypical adenomous hyperplasia just by having 4 cycles a year. And these individuals were not particularly obese, BMI of maybe 37, 38, so not 45 or above. So these are concerns I would have. I think you need to have some sort of progestin withdrawal if they're not sexually active about every 2 to 3 months. If they're sexually active, then use a contraception that will protect the endometrium, whatever your choice. Oral contraceptives, progestin only, IUD, progestin releasing IUD.
In patients with the primary ovarian insufficiency, we find that the FSH is high and the AMH is low.
Right.
Yes.
Yes.
Sometimes, which is rare but can be seen, that we find low AMH but also low FSH. What's your explanation?
So AMH in individuals, and we use AMH as a and it's grown as a quote reliable marker for ovarian reserve. And what we're finding is in women with hypothalamic amenorrhea that have actually adequate ovarian reserve, the AMH is in the normal range, but lower than what we would expect for their age. And when we take them to IVF, their ovaries explode, literally, in contradistinction to the AMH level. We would not have predicted that response. So it isn't as as, because we're just learning about AMH in a big way. So I'm not sure that the AMH is an exact predictor of ovarian reserve. Now, the FSH being low is an issue because it tells you you have decreased hypothalamic drive. That's all it tells you. So in those individuals, you can try and drive the ovary and see if you have any response. So I wouldn't give up on them if fertility is an issue. If fertility is not an issue, then I would replace them with hormones and periodically check the FSH to see if it rebounds. In people with POI, we see a fair number of reproductive age individuals that have had chemotherapy or radiation-induced POI due to childhood cancers. And this one I can't even explain. We just had a woman with Wilms tumor radiation that used her sister as a egg donor, and she had FSHs in the greater than 100. In order to prime her uterus, we gave her low doses of hormone replacement for 6 months to induce vascularity in the reproductive system so that the endometrium would be more receptive and vascularity to the blood flow to the uterus would be normal. She conceived on her own after having amenorrhea for 6 years and had a spontaneous pregnancy on hormone replacement therapy. Now, we obviously continued. She's currently at 20 weeks gestation, so we'll keep our fingers crossed to see if the radiation effects to the uterus will also affect the placentation long term, but that's a concern. So these things happen on low-dose hormone replacement therapy. Even individuals with supposedly low or undetectable AMH following chemotherapy. I put them on hormone replacement therapy. They're in their early to mid 20s and say, if you get pregnant, it'll be because of that, not because I've overdriven your system with high doses of gonadotropin or anything else, because they're driving their ovaries directly with FSHs in the 60s, 70s already. So it's like they're constantly on their own injectable gonadotropins.
You did answer another question, thank you. Going to another question, what's your impression about the term subclinical hypothyroidism as a cause of oligomenorrhea, amenorrhea, implantation failure? It's used in the reproductive technologies and so on.
So Dr. Bedaiwy has written an article about that, and he should send the reprints to the folks at Assiut so that they appreciate it. But the one thing that many people don't recall is that the TSH and TRH secretion is pulsatile. So when you measure a hormone that is pulsatile, the timing of when you get the level will have a variable threshold, okay? So usually the T4 and T3 at the peripheral levels are in the normal range in subclinical hypothyroidism. So you're looking at TSHs between 2.5 and 3.6 or something in that microunits per ml in our lab. And so the pulsatility of TSH will range from about 1 to 1.5 milliIUs. So if you're measuring a TSH of 3.2, the next time you measure it, it might be 2.4. Okay, so is that really subclinical hypothyroidism? So you're using a static measurement for a dynamic pulsatile secretion. Remember, TRF is a neuron that secretes a neuropeptide. So it is firing just like GnRH, but not as a pulse oscillator every 60 to 90 minutes. It is much more variable, but in terms of secretion, it's pulsatile. Okay?
Okay.
So that's my caveat is measure it more than once before you make that diagnosis.
Okay.
The other thing, the other thing is peripheral levels of T3 and T4 do not represent what is going on in the cell. So the metabolism of TSH and T4 is a carrier molecule, as is TBG. And so it's converted and deiodinated at the intracellular level to T3, which then binds to a steroid-like motif in the nucleus. So we're looking at a steroid, even though it's not quite a steroid, it's an indole, but we're looking at that. And so we have to look at the intracellular, what the brain is seeing, as opposed to what we think is happening in the peripheral blood. So you have to think a little bit deeper. One of the things I've found as I get older is we need to teach individuals not to just memorize things, but to think about deep down what is going on in the body beyond just measuring the hormones. Look at the effects, and then you have to look at the effects and then begin to go level to level to level. So you're talking not only the serum levels, but the carrier proteins, which are essentially circulating receptors for steroids. And then you look at the free steroids, which do most of the action, and then look at the transcriptional activity. So as a clinician, we should learn all these components. We don't have to get down to the nitty-gritty of molecular biology, but at least those basics.
Just to add to what Dr. Lu mentioned about TSH specifically and hypothyroidism, in addition to the paper that he alluded to, we just looked into the temporal trends of TSH in patients with a history of recurrent pregnancy loss, where we measured TSH with HCG at the beginning of each pregnancy. And we followed that up to 4 pregnancies, whether this pregnancy continued to term or whether it ended with a miscarriage or a second trimester loss. Irrespective of TBO, actually, this is going to be in the SRM, we just submitted it actually. Irrespective of their TBO status, there is no change from one pregnancy to the next in terms of their TSH assay. We didn't measure T3 and T4 because the Ministry of Health and here doesn't want us to measure T3 or T4 unless the TSH is above a certain limit.
They're right. They're absolutely right. I would not. If I sat on that committee, I'd say, can't measure it. It's a research test.
So they are trying to use a cost-effective approach.
Yeah.
So,
Canada would not pay
yes.
for it.
So I have seen it over and over again that if you replicate the assay, if it's not really in the range above 4 or 4.5 TSH-wise, I wouldn't worry about subclinical hypothyroidism before that. I know people treat between 2.5 and 2.5 and 4, and that is the study that Dr. Lewis alluded to. So between 2.5 and 4 plus, actually 4.2, even if you treat, there is no difference in the outcome in terms of ongoing pregnancy rate between treated with synthyroid versus untreated. This is RBM online, so I can send you the article.
Okay,
Yeah.
thank you.
Excellent.
What do you treat, galactorrhea or hyperprolactinemia?
So interesting. The galactorrhea is a bioassay for prolactin. The measurement of prolactin is an immunoassay. Okay, so if the galactorrhea is occurring, the prolactin elevation may be transient, like at night. So you're measuring it during the day. And so there may be individuals, because prolactin does go up when you sleep, when you're asleep, that have periodic elevations in prolactin that you're not picking up. So if they are amenorrheic and they have galactorrhea, I would treat the galactorrhea. If their prolactin is normal, they don't have galactorrhea, but they are amenorrheic, and it's not due to that. So understand the separation of an assay, which is an immuno recognition, from the bioassay, which is the breast. Okay? And this is why I emphasize this in my talk. Begin to think about the body as the bioassay rather than just measuring a hormone.
Yeah. For girls with gonadal dysgenesis, we sometimes need to induce their breast development because they are hypoestrogenic. What's the program for that? What hormones can we give for them? Should
Sure.
we add progesterone or estrogen or both and so on?
So I do this for transgender patients. So you want to start with essentially a menopausal hormone dose of estradiol. You can use oral, you can use transdermal, whatever is convenient. And after they get to the Tanner stage 2 level, you should add some progesterone. And because they have a uterus, they may not have a uterus, depending on the level of their dysgenesis, you would still need to add some progesterone. And I would use the menopausal hormone replacement dose. There's nothing looking at dose response effects, but there's very good histologic studies and molecular studies that suggest that the progesterone does make a big difference in the globular shape of the breast as opposed to the cone-shaped breast, which is the ductal development predominantly without the acinar development.
Yeah. In a patient with amenorrhea, when can we measure the FSH? Should we have to induce withdrawal first, then to measure it during the first 2 to 3 or 4 days of the cycle, or to do random assay for the FSH? And this also applies to the prolactin.
Yeah, so you're really looking at FSH as a marker, going back to the ASRM practice flowchart I showed you, that algorithm.
Yeah.
So if you randomly measure it and it's above 15, and you know they're not in the mid-cycle FSH surge, then it's shows some evidence for ovarian resistance in terms of ability to put estrogen out. So you're doing two things, and this is one of the things I do. I look at the FSH as a contemporary measure of hypothalamic drive, and I look at the cervical mucus as a integrated measure of estrogen response. So if you don't want to do the cervical mucus, you can do the FSH estradiol together. So you're looking at the driver and the output. And so if the driver is elevated and the output is low, that tells you the ovary is reduced in ovarian reserve. Very easy to do.
Those patients with the primary ovarian insufficiency, how can we counsel them, especially if they are not interested at the oocyte donation programs, to counsel them for?
Well, with Muslims, it's difficult to, I think there's a religious prohibition of using donor oocytes in gametes, period. That's been my experience. So I think just a regular hormone replacement therapy and periodic intimacy, as they normally do, is your only real answer to that dilemma. The publications vary, but in someone with POI, the pregnancy rates vary depending on who you read, from about 10 to as high as 20% of women on low-dose hormone replacement therapy. Now, what I mean by low dose is transdermal patches below 50 mic per day and below, and micronized progesterone 200 or below. When you get above a certain level of estrogen progesterone, it does suppress the HP axis. So you want to allow that HP axis to be able to activate and continue to be at a high level. Because if you measure the FSH when you are on hormone replacement therapy, FSH is still elevated above 15. So you're constantly driving that ovary. So whatever eggs that are of the maybe 300 or so eggs remaining in the ovary, if one of them pops out and there's sperm in the system, you're going to most likely be close to getting a pregnancy. Yes.
The transdermal is not available in Egypt. Can you provide an alternative protocol?
You can use a gel.
Well, that's again needs probably a compounding pharmacy in Egypt. So provide another
really?
alternative.
Well, I mean, the oral estradiol, 2 milligrams and below. Oral
Okay.
estradiol.
So you would give that 2 milligrams or below daily.
Right.
When would you put estrogen, progesterone in this equation? When
Just
would you
use
stop
the
progesterone?
calendar month. First 12 days of each month, 200 milligrams orally. They should get a period with it.
It
And
doesn't matter if it's the first 12 days or the last 12 days. I know the
doesn't matter.
answer, but I'm
It's
trying
easier
to.
to remember the first 12 days because
Okay.
for the last 12 days, you have to count back because some months have 31 days.
Correct. So, all right. So, yeah, that's very, very. That's a classic paper that came out first with the BOI treatment, and Dr. Liu used to quote that they sporadically ovulate up to 20-30% of the time, and their pregnancy rate is between 5 to 10%. Do you agree with the numbers?
No, I think it's higher than that, depending on what you read. But it's not zero, definitely not zero. And so, and the literature would suggest if it's beyond 2 years of hormone replacement, odds of being pregnant are close to zero. So the idea being that if they are going to respond to this type of regimen, they're going to respond within the first 2 years. I've seen an occasional one remote from 2 years, 3 or 4 years out. But what you tell the patient is do a urine test if you miss your menses when you're on the progesterone, after you finish your progesterone. You take the estrogen every day. You don't deviate from that.
I'm focusing on this because egg donation is not allowed in most of the Middle East countries. So for those patients with premature ovarian failure, IVF is not a practical solution. They think that it is, but it isn't. So really, I think it's very valuable that you are sharing your expertise and the direction with this simple approach, because that's very much their only hope when it comes to carrying a child.
And actually, Mohamed, if that's an issue, we should probably co-author a publication with our experience, because I've written some reviews on POI, but we haven't compiled our data. We have a fair number of oncofertility patients that come back after chemo-induced POI, and so we can sort of report on that.
Sure.
Probably 15 or 16 patients. So I just haven't been tracking them, but I'm pretty old, so I see many, many years of data.
Yeah, absolutely.
One last question, please. In PCOS patients, sometimes, as you mentioned, that there is increase in the LH, sometimes there is increase in the androgen levels. How can we clear this hormonal noise prior to doing the induction of ovulation?
So I ignore the androgen and gonadotropins and just induce. So it depends on the duration of the amenorrhea. If the duration of the amenorrhea is more than 8 to 10 weeks, I usually, and I know the NIH that didn't do this in their study, I usually will bring on a menses with progestin and then start the ovulation induction. I pay no attention to the androgens or the gonadotropins at all. So what I'm worried about is trying to impose additional estrogen progesterone production on a thick lining, in which case your endometrium may be not receptive. And also they tend to bleed when the lining becomes too thick during the follicular phase of stimulation.
Yes. Okay, and now I have finished my questions.
Well, actually, Mahmoud, thank you very much for excellent management of the question and answer part. And Dr. Liu, as always, is a wealth of information and unique expertise, particularly with things that requires complex understanding of neuroendocrinology. We always learn from his personal expertise and his knowledge. I'm so grateful, Dr. Liu, for your contribution tonight. It's quite valuable. given the wealth of information and also given how rare people are feeling comfortable talking about these topics these days, unfortunately. So thank you again, and we
All right.
extend an invitation for you to visit us in Egypt, hopefully soon once the COVID-19 is over.
Well, yeah, that could be another year. Hopefully the vaccines will come. I understand there will be 1 billion doses donated from the WHO. So hopefully the Egyptians will get a significant share of that. But I suspect that will probably double in the next 6 months. I don't think that 1 billion doses are going to cut it.
All right. Well, send my greetings to everybody in Cleveland and to Dr. Lynn Lu. I see her in the background. And thank you again for valuable contribution, Dr. Lu.
Right.
And thank you, everybody, for your attendance.
Thank you.
Our next webinar will be on July 3rd. We'll send you the announcement. And you, actually, that would
July
be
4th.
July 4th. I'm always having problems with dates. So thanks, Professor Tariq, as always, correcting me with that. So July 4th, same time, and it's adenomyosis associated infertility. Professor Tariq will be the moderator, and I will have the honor to speak to you. So prepare all of your questions about adenomyosis. We'll have a great session, hopefully, and you have a great night. And thank you very much for your attendance.
Thank you, sir. Thank you.
Bye-bye now.
Bye.
Bye.